All right, Athens, can you see the slides now?
No. I think we're trying to turn on the projector.
That would help. Someone turn on the projector quickly. Albany and Savannah, can you guys hear me and see the slides? Okay, good. All right, we're going to get started while Athens gets the screen up. You guys have a copy of these slides, and we need to stay on track today. I'm going to lunch with one of our faculty candidates today, so make sure we put on a good show for him, get a new faculty member in here. That'll be a great thing. Before we get started today, I've changed the schedule up a little bit, and I'll announce this again at the very end in case it's coming late. But we're not going to have class on Thursday. Thursday's the Southeastern Residency Conference in Athens. I will be there with our residents and the Sunday. I can't desert them, but it'll be a good thing for you guys. And I have something for you to do on Thursday that's important that I'll talk about at the end of the lecture. But we won't have class there class time on Thursday. That lecture, DI-directed clinical services, will be on next Tuesday, along with a exam review. You guys are ready for the final exam, so you'll smoke this class and do really well, and I'm excited about that. Today we're going to finish up about pharmacist role in antimicrobial stewardship. This gets to more of the practical things. Last time was the big global view. Now we're going to focus on some very specifics. So after this, you should be able to define specifically antimicrobial stewardship. You should be able to describe a specific role for pharmacists in the hospital setting. We'll talk about the community setting later, because that's going to be something I want you guys to think about. Because as we speak right now, there's very little antimicrobial stewardship going on in the community. That's a travesty. We have to fix this. It's up to guys like you, coming out, graduating with fresh ideas to get these kinds of programs in the community. They have to be there for good patient care. Describe specific role for pharmacists in the community setting. Okay? That'll be a challenge for you. Describe demonstrated values of students' participation in antimicrobial stewardship. Students on my rotation doing very simple, straightforward antimicrobial stewardship activities saves the institution a lot of money and creates much higher quality patient care. So it's not difficult to do, and I'm going to tell you about some of those things that we do. Here's the definition. It's the optimal selection, dosage, and duration of antimicrobial treatment. Okay? The selection, the dosage, and the duration. Those are all important things. Treatment that results in the best clinical outcome for the treatment or prevention of infection with minimal toxicity to the patient and minimal impact on subsequent resistance. So there's a lot of things going on in antimicrobial stewardship. You know, once an antibiotic comes on the market and starts to get used, pretty soon we see resistance. So if we can prevent that or slow it down, that's a good thing for us. It is multidisciplinary. I mean, that goes without question. It takes physicians, pharmacists, nurses, hospital epidemiologists, the micro lab, all those folks working together to get this to work well. And positive outcomes have been documented. If you do my rotation, I will make you read this article. Because it's really cool because it outlines a lot of studies that have been done that show the value of different types of antimicrobial stewardship activities. Now there's some hard ones to get accomplished, and there's some easy ones to get accomplished. I want you to know the difference between these two. The easy multiple choice question would be, of the examples described in class, which ones are relatively easily implemented? Okay? A, B, C, D, you see what's there. The hard ones are things that involve the disease treatment guidelines. Now these have to be done either institution specific, or if you're thinking far ahead in the future, in the community specific for the kinds of organisms that grow in that particular community. For example, there's methicillin-resistant Staph aureus is more common in some communities than other communities. So you just can't have one broad spread treatment guidelines for everybody. And in the hospital, I'm looking out the window, I can see the Children's Hospital. I know that directly to my left is University Hospital, City County Hospital. And if I can see around the bend over here, out the other side of the building, I can see the VA Hospital. 3 hospitals within a block of each other. They all have completely different antibiotics or sensitivities to bugs in their organizations. So even those 3 institutions on this, basically a block away, they all have to have different guidelines. So same thing applies in the community. That's what makes it hard. You've got to be able to come up with the right empiric choices for what organisms are likely to be an issue for you. Once you get culture and sensitivities back, you have to narrow the therapy based on culture and sensitivities results. So you start with empiric therapy, and once you get the culture and sensitivity back, you narrow the therapy to a drug that's specific for that organism, so you're not creating the potential for development of resistance of all these other organisms. You got to do it for the proper length of therapy. Now, as we progress, I've noticed that over the years, some of the therapies for infectious diseases have shortened in time. That's pretty exciting because one thing that you can do is get the patients out of the hospital quicker. We used to have, everybody had pneumonia, got 7 to 10 days of therapy. Now we have 5 days of therapy with the appropriate antibiotics, probably plenty enough to treat community-acquired pneumonia. You've got to go long enough for some of those indications to have long therapies, like endocarditis, 4 to 6 weeks of therapy. If you stop that early, you've knocked out all the easy to kill bugs, and you have these resistant organisms hanging around. So the reinfection can be really hard to treat. So, and from that you develop your antimicrobial guidelines for your institution or your community or whatever. That's hard stuff to do. That requires a lot of work. But you guys have all the skills to do that. You've learned that in classes, this class and other classes, to help you get started doing some of that stuff. And you'll certainly learn more about that on IPP or patients. There are some easy ones to do too. These are easy. There's no excuse that this shouldn't happen everywhere. For example, adjusting the dose of an antibiotic based on renal function. A lot of the antibiotics have renal toxicities. If you don't adjust them, you get more toxicities. One kind of sideline of this is when you lower the dose of renal dosing, patient with impaired renal function, you also cut down the expense of the antibiotic because you're using less of it. So it's kind of a twofold advantage of doing that one. Now, get this in the back of your mind. That's easy to do in the hospital because I can push a button and get the lab results. How are you going to do that in the community? Somebody comes in with a full dose of a particular antibiotic, who really needs to be adjusted for renal impairment, but you don't know if they have renal impairment because you don't have lab access. Something's got to change in the community to make that easier, but in the hospital it's really easy to do. But that's an area you might want to focus on, a place that we could maybe develop something for community practice. Automatic dosing switches. As new guidelines come out, new evidence comes out, dosages change, intervals change. Matter of fact, for metronidazole, we've gone from Q6-hour dosing to Q8-hour dosing as the standard. So things like that, we can automatically switch those in the hospital. Can't do that in the community. Why not? You know, what's preventing that from happening? Okay, but again, hospital, these are easy ones, so that's how I'll answer the question. IV to PO conversion, somebody who's on IV therapy, converting them to oral therapy as soon as their GI tract, you know it's working, especially those antibiotics are 100% bioavailable. Why not just give them PO? Get the patient up and walking better, they get out of the hospital clearly 1 to 2 days earlier. It's a no-lose proposition. It saves a ton of money, prevents infection from line infections, prevents the patient from not being able to get up, they have to walk around with that IV pole hanging on. And if you've ever had an IV, and the first thing you want is to get that IV out. It's uncomfortable, it aches. It impairs movement in the bed, can't eat well. So converting people from IV to PO is really good. There's some specific programs. I'll talk about the one that we used for Zosyn a while back. We kind of changed the approach to that. And then pharmacokinetic monitoring. When I first got to what was then Medical College of Georgia, I think I might have told you this before, there was a physician who called me the little boy in the pharmacy practicing voodoo because I wanted to help them dose aminoglycosides pharmacokinetically. It was voodoo. Well, these days, you don't have that problem. You've got physicians beating the door down. Can you please help us with pharmacokinetic monitoring? At AU and many other places, it's automatically done. If you get an order for vancomycin at our hospital, it says vancomycin dose per pharmacy protocol. At that point, pharmacists can take over ordering labs, peaks, troughs levels, renal serum creatinine levels, anything else that might need to be needed surrounding the use of that antibiotic. But those are relatively easy. The bottom ones are relatively easy in the hospital. The top ones aren't easy. It requires a lot of work on your part with the multidisciplinary team. So know the difference between these two sets of stewardship activities. Renal dosing, for example, basically, there's 2 different types of renal dosing. There's renal dosing, which is basically 1 to 2 times a day. That's 2 times a day. There's more than this now because the slide's a couple years old. 52 antimicrobials non-formally require adjustment for renal impairment. And that's a lot. I mean, that's a big job. This is one thing. Here's an example of the chart we developed for some of our antimicrobials. What the normal dose is, if the creatinine clearance is greater than 50, 10 to 50, less than 10. These vary depending on the drug. We've updated this many times. I just want to show you what a difference it makes. Somebody has good function versus somebody with bad function. Take a look at the meropenem, for example. Time this was non-formulary, it's formulary now. The normal dose is a gram Q8, and if you have a creatinine clearance between 10 and 50, it's Q12. Less than 10, it's 50% of that every 24 hours. Big significant changes in dosage. You guys should know most of that. Just principles here, things to think about. Some require no dosing change, but sometimes the physician thinks, oh, they've got renal impairment, I better give a lower dose. Not true with the drugs. You can see some of the ones here use 100% of the dose, even if they have severe renal impairment. So help with that is antimicrobial stewardship. Easy to do. No one will fight you on it. The trick is to adjust, to get programs in where the pharmacist has the ability to adjust it automatically without physician orders. We have that set up in our institution, many other institutions. How you might do that in the community is a challenge to show you how to think about that. How much you think about it in a little bit. Some automatic dosing switches. When ceftriaxone first came on the market, the normal dose was 1 gram every 24 hours for just about everything. But it was the first once-a-day cephalosporin. Physicians could not get it in their head that 1 gram once a day would be enough, because in the package inserts, there were a couple indications where you might use 2 grams every 12. For example, meningitis. Well, early on, we saw way overdosing of this particular antibiotic. So we set up a program that if anybody dosed it outside the range for the indications, pharmacists could automatically switch it to the correct dose. You wouldn't believe how many 2 gram Q12 doses I've switched to 1 gram Q24. Fewer side effects, just as efficacious, less expensive, and it's a no-brainer. Same thing I already mentioned, metronidazole used to be the standard Q6 hours, now it's every 8 hours. Kind of a bizarre thing. In our computer system, it defaults to Q6 hours because that used to be the standard dose. So you have to physically go in and change that every time. And you can't forget to do that because physicians will forget to do it. IV to PO conversions. All of these drugs on this list have close to 100% bioavailability. Now there's an exception, like ciprofloxacin, I think 500 milligrams of the oral is equal to 400 milligrams of the IV. But those we have charts to dose them, so it's really easy to convert. All these things, we do it automatically. We don't ask the physician's permission. Okay? And just to throw in a couple of extras, while we're looking at antimicrobial stewardship, we always take a look at formaldehyde and proton pump inhibitors. Those are 100% bioavailable too. We can switch those on the market as well. So kind of a 2-for-1 benefit. Now, this is some specific programs that we've done that are pretty easy to do. Zosyn, when it first came on the market, so you can plug in another new antibiotic for this. We said, okay, we want to make it available for certain kinds of patients. It's super broad spectrum. We don't want it overused. So what we did back in the old days was in the physical chart, we put a note that said, okay, you've got this for 72 hours. At that point, please review culture sensitivities and change to a more specific antibiotic. And we did this manually. It was a big role for my students and I would go through and try to find the charts and put all these things in the charts. It was very effective. Now we can do that electronically with the infectious disease folks. When they go to order particular antibiotics, it will pop up and say, why are you using this? And they have to pick one of the reasons. And we call that criteria-based antimicrobial prescribing. So they don't have to ask infectious disease. They see what it really should be used for, and they pick one of those to let us know how they're using it. Sounds great, right? Well, because it's a great educational program in theory, but on rotation, we've had, for the last, I think, 5 rotations with my students, we've monitored that. It's great for the students to learn the criteria by which these broad spectrum antibiotics are used. It's a great learning system. But we're actually following up with physicians' orders to see if it if what they marked is truly what the patient has. Any guesses as to what percentage of the time the criteria is met? It's a rhetorical question, I'll tell you in a second. I want you to think about it. It's about 60%. That needs to be 100%. And because we're in a teaching environment, we have to constantly educate to prevent that from happening. It hasn't gotten much better. It's been at 60%. That's because people change teams, and all of a sudden we're going to educate another group of people. In a community hospital, that would be a little easier. Okay? It's what you've got to train. It's the same group of physicians all the time, and that works well. So just another kind of thing to think about that you could do helps with antimicrobial stewardship. So some of these broad spectrum, very niche kind of antibiotics, it really should be, patients can benefit if they use that very specific niche. Now the hard ones are things like, that I mentioned on the slide earlier, they require a really good knowledge of infectious disease pharmacotherapy. Well, who has a really good knowledge of pharmacotherapy, infectious disease stuff? You guys do, right? The pharmacists and the infectious disease physicians. That's a marriage that really needs to happen at the community level and at the hospital level. Now, in our institution, we have that. We have an infectious disease pharmacist who works hand in hand. Her office is right next door to the chief of infectious diseases. So that goes on very easily. Also, there's a antimicrobial stewardship committee that's a subcommittee of Pharmacy and Therapeutics Committee. That group gets together. It's pharmacists, half pharmacists, half physicians. And a microbiology person, a couple of nurses. So it's multidisciplinary to talk about how we're going to do some of these things. Now, to do this, you have to have a good knowledge of pharmacotherapy of infectious diseases. Well, students tend to want to memorize bugs and drugs. Okay? That's not the way to learn infectious disease. Okay? I will ask you that on the exam. True or false? Memorizing bugs and drugs is the way to understand infectious disease pharmacology or some question like that. The answer is no. You don't learn it by memorizing it. Okay? But I'll tell you how to learn it. It works really well in a couple seconds. So what I'm going to do here for the rest of the time is talk about some drugs and bugs. I'll tell you what they are, how the drugs and bugs match up. But don't study those slides whatsoever. Do not study those slides. That's not how you're going to learn it. The way you learn it is look at the infectious diseases that are out there, and what are the empiric choices for those, because the empiric choices are based on the bugs they cover. So if you learn diseases, drugs, and bugs, it's easy to learn it. And again, don't memorize this. This comes from APPEs. So every time you have a person with community-acquired pneumonia, I'm going to show you what you're looking at. This is a little bit older version. We update this every year because of new sensitivities, but you'll get the idea what I'm talking about. So here's all the antibiotics that I try to teach my students about imitation. This kind of covers a lot of things. And here's the bugs. Just so you'll kind of get familiar with, somebody says aerobic gram-positive cocci, that's those. I won't ask you this on the test, okay? This comes with experience. You see it a million times on APP rotations. You'll know this, okay? Don't memorize this for any exam. Gram-negative aerobes, that's what they are. Anaerobes, that's what they are. Now here's bugs and drugs. I did it just to generally show you, but don't memorize this. Just look at the slide and say, wow, that would be hard to memorize. I'm not going to do it. Okay, that's the expectation. But I gave them to you because some students want to know bugs and drugs. Well, that's it. Here's what bugs cover the anaerobes. Now this will come up a lot in rotation. But again, don't memorize bugs and drugs. Diseases, what bugs cause those diseases, what drugs are used to treat those diseases. That you can learn. It becomes second nature to you. And you've seen it a couple times. I'm going to give you an example of this and show you how it works. Okay, let's say community-acquired pneumonia as an outpatient. On the left-hand column, I've got a patient who has no cardiopulmonary diseases. They just have community-acquired pneumonia. I think I can treat them on an outpatient basis. There's some criteria that tells you whether or not to treat them on outpatient or admit them. You'll learn that on APPEs. But the organisms that cause that are listed for you there. And the initial empiric therapies are listed for you in the next line. Some alternative therapies are listed for you in the next line. So guess what? Those drugs cover those bugs. And after seeing a couple of community-acquired pneumonia patients in the clinic or on rotation, you'll say, oh, we started that patient on azithromycin, 500 milligrams on day 1 and 250 for 4 days. What bugs does that cover? Well, what bugs cause community-acquired pneumonia? There they are. Now you get them all matched up. You could use doxycycline. Covers the same bugs, basically. If you got a patient with cardiopulmonary disease or any other modifying factors, which this is an ID class, this is a principles class, so don't worry about those right now. You've got those same bugs, plus maybe a couple of other bugs. So now you want to think about maybe levofloxacin as an alternative. It's a little bit broader, covers some of those. Alternatives would be azithromycin, but then add either augmentin or cetiroxine to it, because that helps cover all those potential bugs. Okay. So again, don't memorize this. I'm just showing you the principle. The way to learn bugs and drugs is bugs, drugs, and diseases. A bit further, community-acquired pneumonia, and you're going to have to admit the patient. With no cardiopulmonary disease, it's usually these bugs. And you're going to use ceftriaxone, azithromycin. We still use that. This is an old slide, but that's still the 2 drugs we use because they're great for coverage of those organisms. An alternative therapy is listed there. You could also use levofloxacin, or now we're using moxifloxacin, I think, instead. All right, community-acquired pneumonia, inpatient in the ICU. Now there's 2 things to think about. Does the patient possibly have a Pseudomonas risk? If they do, you've got some coverage down there. You've got to add something to cover Pseudomonas. If not, there's the drugs, and there's the bugs, there's the drugs, and some alternatives. So this seems overwhelming if you just think about it, but once you've been at APPE and seen this 3 or 4 or 5 times, it's with you because you've taken care of a patient and actually used the stuff you had in class and applied it to a patient. When you apply it to a patient, you remember it. I hate to break this to you, but you're not going to remember a whole lot of pharmacotherapy. Okay? You studied it for a test, and after the test, you dumped it to put new stuff in there. And that's kind of simplification. But you do better, because I do it. But when I take care of the community-acquired pneumonia patient for the 15th, 16th time, I don't have to think about it. I know the drug, I know the dose, I know which organisms are going to cause it. That's when you learn it. It's when you practice it. Okay? So APPEs are so much fun. It's very exciting because all the stuff, pharmacotherapy, all of a sudden it becomes alive for you. And you get excited when you learn bugs and drugs and diseases. It's fantastic. Health system acquired pneumonia. Now we're worried about other different kinds of bugs. And so you've got to think about other antibiotics to use to treat. So if you're suspecting MRSA in a ventilated patient, or a nosocomial acquired infection, now you've got to add vancomycin, cover MRSA. Late onset health system acquired pneumonia. That's a whole different type of set of organisms because the patient's been in the hospital for a while. Now they've been exposed to all those other nosocomial organisms. And it gets a little more complicated. And you'll look at the bugs, see what drugs you're using to treat, and you'll learn bugs and drugs and diseases. Just to show you one more example, sinusitis. Most sinusitis is viral. You don't use antibiotics. Contrary to what you've seen in the community pharmacy, people come in, they get a Z-Pak. They don't need the Z-Pak. What they need is a good decongestant or a Gedipot, and after a few days, they get a whole lot better. If it looks like they do need, and we'll get more into this in APPEs, do need an antibiotic. It's typically Staph pneumoniae, H1N1, the organisms listed here. Amoxicillin, doxycycline works quite well because it covers all those organisms except the viruses. Obviously, you know that. Nosocomial sinusitis, that might be something bad, like Acinetobacter, Pseudomonas. Now you're going to have to put in some bigger gun antibiotics to cover those organisms. Okay, so again, this isn't for you to memorize. It's for you to remember that the best way to learn bugs and drugs is to throw in the disease part of it. Once you learn the empiric therapies, you know those drugs cover those bugs. And once you get cultural sensitivities back, now you know which more narrow spectrum agents cover those bugs. And so you kind of got this learning process that's just thrown up in your face, taking care of the patient, and you've learned it. Okay? You don't learn it pharmacotherapy, you don't learn it by memorizing. So I'm going to ask you any questions, nobody stressed about these complicated slides. But developing these slides, I do need to mention this. We develop these slides based on what organisms we know cause the diseases, and then we pick our empiric therapy based on what our in-house cultural sensitivities tell us over time would be the most likely antibiotics that would cover it. So we make sure we cover all those bugs. So every place is, and that's what makes this a hard one to do, is AU has one set of empiric therapy choices, the VA hospital has a different one, the University Hospital across the street has a different one, and if you develop something like this for community type infections, each community would be different. Okay? That's the tricky part. We haven't gotten there yet. Boy, that'd be exciting when we do get there. Okay, some other things. Clinical pearls that can play along with this antimicrobial stewardship stuff. Drug allergies, drug interactions, and some other, and all these antimicrobial stewardship things I'm going to tell you about a little bit more in a minute. Here's some important drug-drug interactions. You should learn this in drug-drug interactions class. Macrolides inhibit P450, 384 specifically, so you've got all those effective drugs listed there. Fluoroquinolones interact with warfarin. I've seen that clinically relevant countless times where patients would bleed because their the clearance of warfarin would be decreased when as soon as they get put on a quinolone. Okay. Or they'd be on a quinolone, they'll start on warfarin, and when they take the quinolone away, the opposite happens. So this is a huge role for pharmacists to play, especially in the community world, where these drug interactions would be recognized by anybody except you. Linezolid, if it's prescribed with other drugs that have serotonergic effects, increase your serotonin syndrome. Clinically relevant drug interactions, you've got to prevent those. Remember, part of the antimicrobial stewardship definition was safety. Aminoglycosides, if you give aminoglycoside, they're nephrotoxic with other nephrotoxic drugs. Potential problem. If you give high dose furosemide with a person on aminoglycoside, the risk for ototoxicity goes up exponentially. Various antibiotics might inhibit the absorption of oral contraceptives. Now that's a controversial drug interaction. Some people say it doesn't really happen. But I'm telling you, it does happen rarely. And that is a very significant drug interaction to the person it happens to. That's when you don't want to be not having warned the patient about it. It's very easy to use alternative contraception during a 5 to 7 day course of antibiotics. You probably don't feel like it anyway because you're sick and you get an antibiotic. So you can just behave yourself for 7 days or use alternative methods. That's an interaction. It's rare, but it can happen. Now, this I want to brag about. On this clerkship rotation, APPE and antimicrobial stewardship, the primary intervention students do is IVPO. That's, I call it low-hanging fruit. It's really easy to do. There's criteria to monitor when somebody can be moved from IV to PO antibiotics. That criteria, the things that you're looking for, happen to be all the things you monitor for a patient who has infectious disease. What's your white cell count doing? What's their fever doing? Are they becoming ambulatory? Is the site of infection getting smaller? If it's skin infection? Are they starting to eat? As soon as all those things, certain criteria met, we can switch them from IV to PO, boom, get them out of the hospital quicker. Narrowing therapy from those broad empiric doses down to once you get cultural sensitivity back, more narrow therapy. Stopping therapy at an appropriate time. We have this bad habit in the hospital setting where patients been getting antibiotics, they need it for 7 days. They're still in the hospital at the end of 7 days. Nurse goes to give it, she's been giving it every day for 7 days, and all of a sudden, hey, it's not on my list to do. Because, this antibiotic has been discontinued, we need to reorder. The physician who's on call knows nothing about the patient, says, okay, here's a verbal order, blah, 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 ciprofloxacin 500, 7 days. It's put back in the system, and now the patient has too long therapy. Okay. Common mistake, we can stop that. Adjusting for renal impairment. Now, if we looked at cost savings alone on students doing just those activities, and this has been reproduced multiple times on multiple rotations, every time I've ever calculated it, it came up within the $500 of the other calculation. For a 5-week rotation, 4 weeks of active intervention, a week of kind of getting up to speed, $7,720. Extrapolate that to 1 year, that's $92,000 worth of student contributions to Animal Code stewardship. Okay, this slide's actually old. This is from a poster we did, oh my gosh, 6 or 7 years ago, maybe even longer. At the time I did this, $92,000 was pharmacist salary. So just student activities justify the salary of a pharmacist. Now that's impressive to me, and students who have been on rotation can feel good about it because they're making these interventions and really helping out, not just saving money, but improving patient care. And the IV to PO one is the big one because we've demonstrated we've got a patient out of the hospital 1 to 2 days quicker once the physicians go, oh my gosh, they're on oral therapy. They can go home. That's the only reason we keep them here. Because they don't think about that. Because they always think IV is what you really need because you're in the hospital. Not true. 100% bioavailability, if the gut's working, same serum concentrations. So the question is, how do we take this to the community? I mean, how do we get this kind of stuff out in the community where tons of antibiotics are used? And because tons of antibiotics are used out in the community, resistance is developing out in the community, which makes it way into the hospital. Okay? We have one nursing home, which I won't name, in the state of Georgia that sends us patients, and every time we get a patient from there, their bugs are resistant, multi-drug resistant organisms, because they're not doing good antimicrobial distribution in that nursing home. Okay? So nursing home is part of the community. So if you're working in a community pharmacy services nursing home, maybe there are some things you can do there because it's controlled by policy for that nursing home. We'll be thinking about these things, and I'll tell you why, because I'm going to ask you to do something, a little challenge for you Thursdays for not having class. I'll show you what that is in just a second. Okay? Let's close this out. Now, next Tuesday's lecture is going to be something called DI-directed clinical services. And as you look through the slides, they're already posted on ELC, you'll say, oh, well, we've heard about this already. We've heard about this already. We've heard about this already. You're right. It's just a summary. It's a nice way to think about all the things we've talked about in your information class that converts into really cool clinical services. Let me show you the last slide on here. This is your assignment for Thursday. Okay? You don't have to do it Thursday, but I want you to do it sometime. I want you to get with your groups, spend a minimum of 30 minutes. Class time's 50 minutes. I'm giving you an extra 20 minutes, okay? Spend a minimum of 30 minutes discussing your thoughts and ideas on how to get some of these things on the previous slide, so you have to look at the slide set. Several of them we've already talked about in this class today. How do we get those things out in the community? I will ask you an exam question about your exercise. So do it. Okay? 100% of you are going to do that little exercise. In the past, I've asked an essay question. I might do that again this year. It takes a little longer to grade. I might not, but I might. And the years that I've done it, I've really enjoyed it because I'll read them and I go, oh my gosh, we have such smart students. If they will take some of these ideas and actually apply them in the community, wow, pharmacy practice will go actually up exponentially. Patient care will be greatly improved. It's amazing when you get with your people to start brainstorming what great ideas can come up. Don't worry about barriers right now. Because there's one in this lecture, if you look through the slides, there's one that would be so cool to do in the community. I think we talked about it once in the community health thing about therapeutic interchange. How might that happen? Why can't we do that? Interchange a prescription for one drug, the same drug in that class is covered by their insurance plan. Wouldn't that simplify life? Those are the kinds of things that we should think about, come up with potential ideas for good, community-based drug information directed clinical services. And of course, the stewardship's one. Therapeutic interchange one. Let's brainstorm these things, okay? Everybody gonna do that for me? Then next Tuesday, we will meet. I'll send out an email to reinforce all this. Next Tuesday, we will meet. This is a very short lecture, so I have plenty of time to go over that exam, get you guys in great shape for the final exam, okay? So like a plan? All right. One more lecture to go, and then this class will be over, and I'll be sad because you guys will leave me. So I hope you have a good time, and we'll talk more about how I want you to use this in the future on next Tuesday. Okay, everybody clear about Thursday? Don't come to class. I'll send an email, I'll cancel all the connections and all that stuff. All right, see you guys next time.